Hello, professional nurses. This is Mrs. Ignacio with your lecture for Nursing 104, Chapter 36. We are going to be talking about loss and grief. All right, so let's talk about loss. And so, what is loss? Well, there's different ways we can express loss. There's different circumstances in which the patient may experience loss. So there's an actual loss and a perceived loss. And so when we talk about actual loss, we have a necessary kind of loss. And so this is unavoidable circumstances. So this is death, possibly divorce, any kind of life-altering kind of incident. And so this necessary loss can be accompanied with a lot of emotions, particularly sadness or despair. Now, there is such a thing as situational loss. An example of that could be a situation where maybe a woman suffers a miscarriage. So that's an example of situational kind of loss. Perceived loss is if the patient feels like maybe they are losing their independence, they're losing their ability to complete their ADLs. And that could happen sometimes as you have a geriatric patient that is no longer able to drive because they have visual deficits. So understanding that loss is really in the eyes of the patient, how it is perceived, and that's going to also affect their ability to cope. Okay. So let's talk about grief. So grief are the feelings that goes along with this loss. And I want to submit to you is that you should be looking at, and I'm going to post this video. It's on the stages of grief and loss by Dr. Elizabeth Kubler-Ross. Okay, so there's a cool video. It has a giraffe, and I'll post a link that goes through those stages of grief and loss. And so the acronym for that is DABDA. So we have denial, acceptance, bargaining, depression. I'm sorry. Did I say no, I said the wrong thing. So DABDA. So that is, let me just write it down so I make sure I'm saying the right thing. So denial, anger, bargaining, depression, and acceptance. I'm not sure what I said before, but it's going to be denial, like, no, this is not happening. Anger, oh God, why did you let this happen to me? Bargaining, God, if you cure me of this cancer, I will go to church every Sunday. And then depression, I'm so sad, I can't go through this. And then acceptance, I accept that I only have 6 months to live and I will do the best to honor my time, right? So that is DABDA. And so those are the stages of grief and loss that are talked about by Dr. Elizabeth Kubler-Ross. That is definitely something you could expect to see for the NCLEX. So when we think about normal grief, really normal grief is something that people experience, and it's after the loss potentially of a loved one, anything that we have a strong emotional connection to, and we end up losing. So sometimes we could lose our freedom, sometimes we can lose our identity, or maybe expectations. And so grief is really a normal part of human experience. And sometimes your patients may have anticipatory grief. So if your patient has been diagnosed with breast cancer and they have to undergo a double mastectomy, they may already start to grieve in anticipation of the removal, the loss of their breasts. Okay, so that's anticipatory kind of grief. Now, disenfranchised grief is grief that really you can't really put your finger on it. And so sometimes we may have, for example, an illegitimate child that has this disenfranchised grief because they can't go to the funeral because they were a child out of wedlock or they were a secret child. So that child, who could be an adult child, has to grieve in private. They don't have the opportunity to bond with the family and to go through the grieving process and to attend the funeral. Okay, so that's the disenfranchised kind of grief. Sometimes nurses have disenfranchised grief because sometimes we can get really close and connected with our patients, especially if it's, for example, I used to work on the oncology unit. We would have patients that would keep coming back. We call them frequent flyers. So you would get to know them over a period of months, maybe even years, as their condition improved, decline, so on. And so it's really hard because when you lose your patient, you can't just go into the patient's room and, wail and with the family because they're processing their grief as well. And it's your job as the nurse to be strong. Now, it is okay though to cry if you're grieving for a patient. And many times our nurses would end up going to the funerals of our patients, and the families would say thank you, and it would be a great time for them to express their gratitude as well as we celebrate the life of our patient. But that's disenfranchised grief. So sometimes nurses go through that. Complicated grief. So wow, there could be a lot that goes on with grief. Chronic grief, a patient may have lost loved ones, one right after the other. There's, different, maybe they've lost a parent, then they've lost a sibling. And so that can really become very difficult for someone to really, they haven't finished processing the first person that they loved that they lost. And so it's really can be devastating for some. Now, when a patient has complicated grief, they may have irrational thoughts. They can have avoidance behavior, so they may avoid things that remind them of that particular person. And so this really can be really I don't want to say complicated, but it can take a toll on the patient because they may feel like, okay, there's no end in sight for this pain and suffering. And so this patient that has complicated grief that could be in the form of chronic, exaggerated, delayed, or mask, they can end up displaying self-harming behavior. So we really have to look out for that. So if you see a test question and the woman says, I'm leaving my daughter's room the way that it is when they drowned, 5 years ago, because I can't bear to go in there. Okay, it's been 5 years. That is, a red flag because usually we give a year. And that's when, after a year, it's not that they forget their loved one, but they need to start moving forward with their lives and accepting the reality that their loved one is no longer with us and no longer coming back. And so that could be very challenging for some. Okay. All right. So when we think about the theories of grief and mourning, there's the stages of dying, the attachment theory, grief task model, Randall's R process, the dual process model. I'll tell you the most important thing is to understand Dr. Elizabeth Kubler-Ross. That's going to be the one that you probably will see for the NCLEX. All right. So things that affect our nursing knowledge base, okay, things that influence the way that we view and process loss and grief. Well, human development. Okay, where are we in accordance with Erik Erikson? Because a 2-year-old is going to process loss differently than a teenager would. So we have to understand Erik Erikson's stages of development. Also, the personal relationship. We could have some siblings that maybe have lost the same grandparent, but one may be more affected because they had a closer relationship. Also, the nature of the loss. Well, was it something that we knew that was happening, or was it all of a sudden? Also, does the individual have coping strategies? Maybe this is the first time they experience a loss, so they don't have these coping strategies. Okay, so socioeconomic loss. Maybe the person that passed away was the sole breadwinner for the family. So now they are going to suffer socioeconomically. So these are all things to consider. Culture. How does this particular patient's culture and background play into loss loss and their expression of loss and grief and mourning, as well as their spiritual and religious beliefs, because some believe that, okay, if you are no longer alive in this world, you are now with your maker. And so it's not necessarily a time of sadness, it's a time of celebration and a rite of passage that everyone goes through. So it's important to understand how your patient views that and respect their wishes. Okay, so critical thinking. So critical thinking requires us to get information from our patients, from the subjective data, also getting information from our own senses. That could be through vital signs, blood work, x-rays, CT scans, physical examination, health history. So we get all of these pieces of information and we synthesize them. We put it together so we can form informed decisions and how we can care for our patients. So critical thinking, we synthesize knowledge, experience, the environment, things that our patient tells us. Critical thinking attitude, we have a questioning attitude, and we do this all in accordance with our professional standards of nursing. Okay, so that's really important. So the nursing process, don't forget the nursing process. ADPI is essential. So assessment through the patient's eyes. So how do you think the patient is feeling about this loss? What has the patient said to you about this particular loss? What are the grief variables? Well, is this loss going to change their ADL? Is it maybe a socioeconomic loss? So we have to think about, okay, what does this loss mean to this individual? And some people may cry, some people may laugh, some people may remain silent. It just depends on the patient, their family, their personality. Sometimes there's cultural ways to express grief. So these are all things that we have to think about. So when we think about analysis and the nursing diagnosis, there's some nursing diagnosis that could have impaired family coping. Maybe the family is not coping well with this grief. Death anxiety, they're really nervous about this pending loss of a loved one. Maybe the individual, the patient has pain. It could be an acute onset or it could be chronic pain. Maybe there's dysfunctional grief. It reminds me of the movie Kingdom Come. And the Whoopi Goldberg's character was the wife, and she said that her husband was mean and surly, and so she put that, I think, on his tombstone. So we have some kind of dysfunctional grief. We also have anticipatory grief. We know that this patient has stage 4 cancer and has been given X amount of time to live, so we know that their time with us is limited. So we're anticipating the loss of a loved one. That's anticipatory grief. So when we're planning, we're looking at, okay, what are the outcomes and what are the priorities that we're going to set, and who are the members of the team that need to work to help the family? Now, the members of the team could be social worker, it could be your spiritual leaders, it could be your rabbi, your imam, your priest, your evangelist, just depending on the request of the patient. Now, implementation, we want to help our patients and their families with any end of life decision making. Not that we're going to make the decision for them. However, we will assist them if they have any questions, if they ask us to contact the funeral home, those kinds of things. We will definitely help them work out those details. And as a nurse that was working on an oncology unit, that's one of the things that I would have to do. So when we think about palliative care is making sure that the patient is comfortable and doesn't die with a lot of pain. We don't want our patients to die with a lot of pain. We want them to die with dignity. So that means keeping them clean, not allowing them to have bouts of incontinence and just leaving them in that incontinence with the attitude as well. They're going to die anyway. So why bother cleaning them up? No, because that's someone's loved one. That is a human being. So even though they're dying, we want them to die with dignity. So when we think about hospice care, right now, our former president Jimmy Carter, is on hospice care. And the last report I received from the news, of course, is that he is enjoying ice cream. So, although he's on hospice, he has 6 months or less to live. He's still able to enjoy some of the basic things in life. Okay, so remember, hospice care, the patient has 6 months or less to live. And I just read an article, unfortunately, it talked about his wife, Rosalind. She has dementia. So, and they are both almost 100 years old. So that's pretty impressive that they live such a full life. Okay, but palliative care is making the patient comfortable. Hospice care is the patient has 6 months or less to live. So we want to use therapeutic communication, and that's open-ended statements, using reflective kinds of statements, and really being empathetic towards the patient and their family during this time of grief and loss. We also want to provide psychosocial care. So that's the mental health piece that goes along with it. Manage any symptoms like pain, any discomfort, and make sure that we are available to the patients and their families to promote dignity and self-esteem. So we want this environment to be comfortable, peaceful, and we want to provide spiritual comfort and hope. Not necessarily you have to pray with your patient, but if your patient invites you or asks you if you feel comfortable, that's okay to do. I have done that with my patients. They say, "Can you pray with me, or can you pray for me?" That's something that, that's going to be your comfort level on what you feel. And just because you're praying with a patient, does not necessarily mean that you have the same beliefs. Well, I don't know. That's going to be up to you. For you to decide. We also wanted to, protect the patient against feelings of abandonment and isolation. Now, sometimes we can't control the fact that the family is present or not. So I've seen a lot of test questions and it says the patient is, dying alone and they're afraid of dying alone. You can't say, well, I'm going to get your family here. Well, you don't know if the family even wants to come. So don't make false promises. That could be considered false reassurance, okay? So please be careful when you're looking at those questions and don't make false promises, okay? Because I've seen sometimes where the family doesn't want anything to do with the person that's dying. They're just waiting for them to die so they can get the will and find out what their inheritance is. Okay, but you also, as a nurse, want to support the grieving family. And after the patient has died, that is one of the things that we can delegate, that postmortem care, to an unlicensed assisted personnel. If the patient is going to donate their organs, for example, if they're going to donate their corneas, you want to close their eyes and apply a moist, sterile gauze to help keep those eyes moist. And if the patient is going to have an autopsy, you'll have to prepare the body. Sometimes there are rituals depending on the patient's religion. For the Jewish patients, for the Muslim patients, they have very strict rituals that surround washing the body, preparing the body. For your Muslim patients, someone of the same gender has to help. So as nurses, what can we do? We can provide the towels, any, soap, any basins, anything that they need to perform their rituals, and give them the time that they need to perform that post-mortem care. Um, Another thing that I do recall from, getting a patient ready to transport to the morgue, removing any lines. So if they have IV lines, a central line, Foley catheter, anything that they weren't born with, you're going to remove that. We will place one tag on their big toe, one tag on their wrist, and then the third tag will go outside of the body bag. And so they have a shroud that we place the patient in, and it's kind of like a big black bag. So when you do transport a patient off the unit, you want to close all the doors, because you don't want the patients that are lying in their beds to see, okay, you're walking down the hallway with, someone in a body bag, because that could affect them, because they can say, okay, wow, another one died, I might be next. So that could affect their ability to cope. So you want to close the doors. And at Centera, we would take the patients down. Security would meet us and place the body in the morgue until the funeral home would come to retrieve the body. Okay. All right, so evaluation is looking through the patient's eyes and what are the outcomes. Examples of these outcomes is that the patient will have end-of-life care and they will still maintain their dignity. They will be free of pain and suffering. Okay, so that concludes this chapter. It was a pretty short one. And remember that as nurses, we see life as it ends and we see life as it begins. And so this is really one of the sacred things that nurses we get to be a part of. So don't take it lightly and respect human life and always think like a nurse. Thank you.